Well, my name is Bob Motzer. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center, and I was the lead investigator for the JAVELIN Renal 101 trial, which is a large randomized pivotal phase 3 trial that looked at combination therapy with Avelumab plus Axitinib as experimental combination versus Sunitinib, the standard of care for people with first-line metastatic renal cell carcinoma. These are my disclosures, and the trial was sponsored by Pfizer with an alliance between Pfizer and Merck KGaA. So just briefly, in terms of kidney cancer is not a rare cancer. In the United States, it afflicts about 65,000 people a year, and worldwide, it's between 300,000 and 400,000. For the most part, early stage treatment with kidney cancer is a surgical resection of the kidney tumor in the primary. But one of the problems with this cancer is that there aren't early warning signs, so about 50% of people will develop metastasis, either at initial diagnosis or following a nephrectomy. There's been tremendous gains in the treatment of this disease. It had historically been considered to be one of the most difficult cancers to treat, with a poor prognosis and an average survival of only about 8 to 12 months when I began treating this disease in the late 1980s. For the most part, the standard of care and the prognosis changed with the development of anti-angiogenesis drugs, or VEGF TKIs. And the drug that really changed the paradigm is called Sunitinib, or Sutent, which is a multi-targeted tyrosine kinase inhibitor. And it's made up the reference standard for this disease ever since 2006, when it was approved in the United States and shortly after in Europe. So there's a number of different compounds that are similar to Sutent, and the one that was chosen for this combination is called Axitinib, or Inlyta. It is approved in second-line treatment for kidney cancer, and it has the advantage over Sutent in that it has less toxicity, specifically liver toxicity, so it combines better with other medications. The other main treatment that we use for this disease are checkpoint inhibitors, immunotherapies, examples, Nivolumab as a PD-1 inhibitor, or PD-L1 inhibitors. And the PD-L1 inhibitor that was used in this combination is Avelumab, which is a checkpoint inhibitor. The mechanism of action is shown here for the combination. On the left, you'll see Axitinib, which is a VEGF-R, a pill that blocks angiogenesis in clear cell carcinoma, the most common type of kidney cancer. And on the right, you can see where Avelumab acts right directly on tumor cells to block PD-L1 and interrupt the ability of the immune system it facilitates the immune system in fighting cancer. So one drug blocks angiogenesis, the other one increases the immune system. And there's been a lot of work, preclinical and clinical, that has shown that if you put the two together, they complement each other, work together to kill the kidney cancer cells. So this is the schema of the trial. It was, the eligibility was first-line metastatic kidney cancer patients who are not amenable to cure with surgery, had metastasis in various organs, randomized 1-to-1 to the Avelumab checkpoint inhibitor plus Axitinib, the VEGF TKI, versus our standard of care since 2006, Sunitinib. The primary endpoint of the analysis was in patients whose tumors express that PD-L1. On the left, you can see a tumor cell expressing PD-L1. So patients had their tumors tested, and if they were positive for that PD-L1 on their tumor, that was the primary endpoint of the trial. The main group that we were focused on the efficacy analysis. But of course, it's important to broaden the treatment population, so we didn't restrict patients to PD-L1 positive disease. All comers were allowed on the trial, and that's represented by the overall population over there. So 886 patients were enrolled on this big global trial that was done in 21 countries and 5 continents. And among those, 63% had PD-L1 positive tumors. There were two primary endpoints in this trial, co-primary endpoints. One was the progression-free survival, or basically the time it takes for the cancer to escape from response to treatment in the PD-L1 positive group, and in the overall, and the other co-primary endpoint was overall survival as well. And those are kind of the two main metrics we've used in the past for benefit for kidney cancer. So it met the primary endpoint in a very early on in an interim analysis, an early look at the data, showing improvement for Avelumab plus Axitinib over Sunitinib in the PD-L1 positive group here, shown by the long median progression-free survival of almost 14 months with Avelumab plus Axitinib compared to 7 months with Sunitinib. And the hazard ratio of 0.61 means that at any time along the course of the trial, there was a 39% reduction in progression or death for patients treated on the combination arm compared to Sunitinib. In the broader group as well, we saw a benefit for the combination of Avelumab, the checkpoint inhibitor, with the Axitinib anti-angiogenic drugs. Again, the median progression-free survival was almost 14 months compared to about 8 months with Sunitinib, and the hazard ratio was 0.69, a 31% reduction in time to progression or death with the combination. We also looked at objective response, which is our metric for how much the tumors shrink down by a standard criteria called RECIST that we use. And so basically in objective response or significant tumor reduction, the response rate was double with Axitinib plus Avelumab compared to Sunitinib, both in that PD-L1 positive group and in the overall population. Adverse events are shown here, since safety is of paramount importance in assessing new combinations and comparing them to Sunitinib. And so adverse events are a measure that the physicians have in evaluating patients for signs of toxicity. And all grades vary from minimal to severe. Grade 3 and 4 are moderately severe and severe. And so about half the patients on each one of the arms over the course of the treatment were noted to have a moderately severe or a severe toxicity. Now, this can vary from diarrhea. You can see grade 3 diarrhea was the most common. Grade 3 diarrhea means an individual had more than 7 episodes of diarrhea a day. On the other hand, an adverse event can mean a decrease in the platelet count, which the patients don't experience at all. So there's really quite a wide variety in terms of how this affects patient outcome. In any case, the side effects were about the same for the combination compared to Sunitinib, and there was actually more of the high-grade toxicities with Sunitinib. So I'll wrap this up with conclusions, and that is, as this trial demonstrated longer progression-free survival and higher objective response rate for the Avelumab plus Axitinib, the checkpoint inhibitor plus VEGFR combination compared to Sunitinib in first-line therapy for advanced RCC. This was very early on at an interim analysis showing a profound effect. The other co-primary endpoint is overall survival, and the data is not yet mature to look for survival in these patients. The combination had a favorable safety profile, and the results support this being a new first-line standard of care, possibly an option for first-line treatment for advanced RCC based on this data.